Super. That's it.
Thank you so much, Professor Mabrouk. That's amazing, because mostly we see videos on which are edited and never like real life. And you know, and when you do this surgery, you always encounter problems that you have never seen, because nobody really shows this. And so I really appreciate that you know, decided to do that this way, because this is so important for people who are learning this. Also, I think it was fantastic surgery, of course. And I would like basically start. We have lots of questions. Like, please, all participants, you can you know, put your questions on the questions answer forum. So we're happy to have them. But I'll start just to, you know, because this is something what always trainees ask me, and also like more and more patients come who are newly diagnosed with endometriosis. So, and for both you, Professor Mexner and Professor Mabrouk, like if you have a young patient just diagnosed based on symptoms, but also an MRE, a disease like endometriosis, and you're really sure that's the case for her pain, and this comes a lot for, like, they ask why, like, what should be first? Should be first the hormonal treatment, or should be first their surgery? And the reason why more and more people ask about this is, like, they know that if you do, you know, are actually having hormonal treatment, you still can have growth of the disease, or you can have symptoms that are, you know, not manageable. And so many of patients will ask, like, why not do the surgery first and remove all the lesions and then suppress? So what's your opinion on this?
I would like to hear the opinion of Sylvia first, to be honest.
Okay. So yeah, that is always the question. But I think it depends on the situation of the personal situation of the patient. How old is she? Is she willing to conceive? Or what is the situation? In my opinion, also in case of deep infiltrating lesions, if you can exclude a hydronephrosis or stenosis of the bowel, if you can try a hormonal treatment, you can try. So if the symptoms are going on under hormonal treatment, under hormonal therapeutic amenorrhea, then the indication for surgery is clear. But before you decide to do the surgery, has she endometriomas, for example? We always take the AMH level also to think about the ovarian reserve before we are doing surgery on the ovaries, because we all know there is sometimes a dramatic decrease of the AMH level, also sometimes after one surgery on one side, on one ovary. And then it's not fair for the patient, because afterwards you have to go to the patient and say, so now it's time to conceive just in this time, or your chances to get pregnant will decrease dramatically. And that's not fair. So always do a personalized management for the patient. So, but of course, if there's a stenosis, a hydronephrosis, or severe pain under hormonal treatment, you have to go with the surgery. Or if she wants to receive directly, then also surgery. That's my opinion. So now I'm looking to hear another point.
So no, it's not another point. It's exactly the same. So yeah, surprisingly, it's exactly the same. So till 27, there was nothing about medical treatment of endometriosis. Okay, so yes, people used to give sincerely and honestly, people used to give GnRH analogs because they were afraid of treating these patients surgically. Most of the medical treatment was that, and I have seen patients that have been on GnRH analogs for 5 years and stuff. This is yeah. So yes, this is, but having said that, I am also convinced that, first of all, treatment has to be personalized. So there is no right or wrong, and there is no cutoff, and there is no numbers. Even in the guidelines, you find a number like ovarian cyst more than 4 centimeters has to be excised, less than 4 centimeters should be excised. This is an arbitrary number that I'm not very convinced. It's a dress, and this is what I say to my patients. I say to her, it's like a dress. What fits you doesn't necessarily fit your twin sister. So it's a dress. Everyone, I am a tailor that has to make a dress. It depends definitely if there is no stenosis, or if there is no urethral stenosis, bowel stenosis, or I would add as well if there is no risk of malignancy or any suspicion of malignancy, because it's not a big topic. It's not that endometriosis is a precancerous, but we have also to consider this. And if the patient is not, unfortunately, we don't have non-hormonal treatment for endometriosis. So most of the treatments that have been on table today are hormonal treatments. So if the patient is seeking a pregnancy and she doesn't want to go through IVF, I think surgery has a place. But I would also try medical treatment before surgery, okay? But I would counsel my patient on 2 points. First point is,
now we lost you, sadly. Hopefully you will come back. Seem like very important questions, actually, points. But Sylvia, thank you. I hope Professor Mabrouk comes back in a second.
I think I'm here.
You get that. Perfect. Please, your 2 points.
Yes, 2 points to my colleagues and friends who are dealing with endometriosis. First point is medical treatment. You have to start it after making a workup for the endometriosis patient. Because what happens now is that there is the magic pill, the Dianogist, that everyone gives Dianogist without making a workup for endometriosis, which is not very good. Second is hormonal treatment is not cytoreductive, so we're not expecting endometriosis to disappear. Endometriosis treatment, medical treatment, is long-term. She will not improve after 1 month, absolutely. We have to try and see. If she improves, that's fine, but the word improves means at least 6 months. If she doesn't improve, surgery.
Yeah, I think you totally, smashed it with these 2 points, because that's actually how we should actually see the endometriosis. And what you point out, which I think comes across the questions as well, is how long would you treat somebody on hormonal treatment, and to say, does it work or doesn't work? And it comes up a lot as well. So I hear 6 months, if you may say so. Professor Mexmed, do you have any other time frame for medical management?
Yeah, as I told before, patients must be bleeding free. That is also a point. Yes, she needs to be bleeding free. If she is ongoing bleeding, then it's not successful and it can't help, or we can't do the decision. And yes, and yeah, I also recommend to try it 6 months. Mm-hmm. Also, yes, we are looking also for the other discomfort, the pelvic floor discomfort. We always recommend to use or to find a personalized models to go on with the symptoms and to improve the quality of life. Mm-hmm. That's the point, quality of life. And then you have, you can go on over many years with this treatment until patients seeking pregnancy. Yes, so young patients. Older ones, it always depends on the situation. Mm-hmm. But most of the people are younger, and that is a good situation. I think my patients, they are coming now earlier, a little bit earlier. So because the awareness of the disease is becoming more popular.
Yes, and there's lots of questions also about using GNR analogs before and after surgery. What's your views on this? Like either to kill them before, to improve the surgical risk? Like, I don't know, like what's your intake of this? Like to give them GNR analogs before and after surgery?
You're unmute.
Oh, this question is for me. So to decrease this risk of surgery, okay. So, well, okay. Hello?
Now I hear you, so once again.
Okay, you hear me. Okay. So the guidelines are with GnRH analogs before surgical treatment, okay? So there is nothing wrong in this. Giving the patient 3 months of GnRH analogs before treatment is good. Technically speaking, it might reduce the neoangiogenesis and the bloods. I am not very much convinced about this, to be honest. But yes, if it is an option that I offer to the patient if she wants to have GnRH analogs before treatment, and also because these patients are young, and I see the patients that take 3 months of whatever GnRH analogs. It's not very easy, I don't know, but this is at least the feedback that I take from the patients, that it's not an easy medication to do for three months. But yes, I used to give Dianogest for some time before, because we used to work in hospital, very, very busy hospitals that have a long waiting list. So she's on the waiting list. While she's on the waiting list, she takes Dianogest. Dianogest in this context is fantastic. That's, again, no conflict of interest, not working for anyone. But yes, in this context, Dianogest is good. But if this is not routine, you can also operate without giving anyone anything.
I see another question here.
I don't know what.
Another question about having or using anti-adhesion gels or solutions. What's your impression on this? Both Professor McNair, what you think?
Yes, I tried a couple of times, but then I had some problems with afterwards, and then I stopped it. So I have not so much experience, and I'm afraid that there is an inflammatory reaction or something else to this compound. But and I think I'm not really convinced about the studies which are available on this topic, because there is no real randomized trials available about it, and the numbers of patients are also not so high. So I'm more skeptic.
And Professor Mabrouk?
Well, I think that myself and Sylvia were in the same school at some time. So yes, okay, as a concept, if you have it and you'd like to use it, you can, but I don't like it. There are some evidence in the literature that supports, but I'm not convinced. Also because the only way to know is to do a real laparoscopy to the patient and to randomize the patients, and all the studies are not powered. And even the one study that they even dared to do a diagnostic laparoscopy to the patients to understand if they formed adhesions, yes or not, was not that convincing. But on the other hand, I am aware of a colleague that had, because we are all doctors now, and we have also medical legal issues and stuff. So he had a serious medical, not serious, but some medical legal issues, because the patient formed adhesions after surgery with endometriosis, which is a normal, natural thing. But at the end, because he didn't use an adhesion barrier, they blamed him. Why didn't you use it? It's available in there. And you know what I mean? But my personal impression is I don't like them, but I have a very good advantage, is that we are poor. So we don't have it in our theaters, and that's why I say, okay, it wasn't available. I'm sorry, this is the reality.
Fantastic.
Moy has apparently an opinion on this.
Thank you. No, I agree with you. I think the best anti-adhesive device that you can do is good surgery.
People are coagulation.
The point that I want to do, I routinely use Omental patch after extensive adhesiolysis in the pelvis. So I tend to divide the lower part of the omentum and attach it to the posterior wall of the uterus or posterior vaginal wall, so that all this, because it's a raw surface where you do the dissection, you don't want it to fall, because the minute that it falls, it's almost certainly going to get stuck. So basically, I leave that patch of the omentum in between. And I don't know about your experiences, Sylvia and Mohammed.
No, we don't do that, only in very rare cases. But I followed also my patients. I often did, in case of extended peritoneal lesions, a complete peritonectomy of the posterior compartment, and I had the chance to do surgery again in 7 of these patients, and I was really surprised about the fine rebuilding of the peritoneum. So I'm always also thinking that the kind of surgery is very important to find the right spaces. And yeah, I think that is the most important point, to avoid adhesions. And in case of very complex surgeries, it's also the adenomyosis, the superficial xerositis of the adenomyosis, which could be also improve adhesion building, I think. So that is also a critical point we don't have to forget.
So from my point, I think that we use omental flaps only when we do segment bowel resection or bowel surgery plus hysterectomy. Mobilize the omentum, and we put as a separate between the vaginal suture and the bowel suture. For the lateral side walls, what we do, and which is years and that we do it, we did also a serious randomized controlled trial in Bologna. About it was the ovarian suspension. So if the ovaries are hanging like this and they attach to the pelvic side wall, we just suspend them to the peritoneum, whatever you would like to, with an absorbable suture that falls after 2 weeks, that's fine. We also sometimes take the thread out of the skin, out of the body, and we just and then it is cut after 5 or 7 days. That's enough. But yes, this is what we use. I agree with you that omental flaps or patches are good in cases of, obviously, if there is this, where we use them in a hysterectomy plus bowel surgery to avoid fistula.
Yeah, we do the same here. So, and from Professor Ekstrom experience as well, it's only for ultra low bowel resection as well, if you want to have an extra protection there. From the panel, I see that from the questions I can read, I think we have covered most. There were some very specific, but then the panel can, or the speakers can actually later maybe answer some of them. The questions are very specific here, if you have time. But from the panel, are there other questions?
Yes, maybe. Can you hear me?
Yes.
Hi. So thank you very much, Professor Maxner, Professor Mabrouk. My question is about endometriosis and cancer. And I have the privilege of working with Professor Maxner in the same center. So I know she does research and my background is more oncological. But what is your your experience with the association, particularly maybe with ovarian cancer and endometriosis? And also, what is your viewpoint on the endometriosis surgery and how does it differ from the oncological surgery? I think that's just a very interesting aspect.
That is a complex question. We can have another meeting now, right? We can start right now.
I know.
Yes, so I think there is a connection. So we know that the endometriosis associated ovarian cancer subtype, yes. But from my but it's a problem later on. So, and I think what we need is that we need to have the history of the endometriosis history at the point of the diagnosis of ovarian cancer. And at this point, nobody is interested to ask about endometriosis, because then the patients have another problem. And we started to build up such a database to document more about the biology of the endometriosis disease. I really think we need that, and because from I think I have an overview about 20 to 25,000 patients with endometriosis, but premenopausal patients. I never had in our clinic, we never had the finding of an incidental carcinoma during in our setting. Yes. So the premenopausal situation, or they are not coming in our clinic because it's suspected for something else. Then the management is another way. Another question. Oh, I think it's really important to avoid later ovarian cancer or extra ovarian cancer. It's very important to clean out the pelvis. So when you are doing surgery, make a good surgery. So with also pick out all the lesions. And also the hormonal treatment, we know that it's also a kind of prophylactic treatment for cancer. Yeah, that are the points I can say to this question.
So yes, from my point, I think that, well, biologically, genetically, and epigenetically, this is another session, so we can spend the day in speaking about this. But from the practical point of view, I have a patient who has an ovarian endometrioma. Shall I scare her, counseling her and saying, oh, you know what, it can be transformed to cancer? Or the question that the patient usually asks you, doctor, can it become malignant? You're giving me a hormonal treatment. Can this become malignant? Yes or no? I think the answer to this is it's not a pre-malignant condition. And this has to be very clear to the patient. Madame, endometriosis is not a pre-malignant condition. Why am I saying this? Because I've seen girls, 15, 16 years old, 3 centimeters endometrioma, and their ovaries are taken out, or the endometriosis is taken out at 15 and 3 centimeters because of the risk of malignancy. This is not scientific, this is not logic, and we have to be very, very clear with our patients. The overall risk of a patient to develop an endometriosis and associated cancer is exactly the same like the patient without cancer, if that makes sense. There is very slight increase in the patients. I've been working in endometriosis centers for 16 years, and I have seen patients with ovarian and deep endometriosis with malignant transformation, and we published this. So it happens. If the question is it happens or it doesn't happen, it does happen. Is it pre-malignant or not? It is not. Do I have a higher risk of developing endometriosis associated cancer as endometrioid or clear cell carcinoma? The answer is like the normal population. Then, if the patient develops an endometriosis de novo in perimenopausal age, 47, 48, 40, this is an alarm. If the patient has an endometrioma that is growing, this is an alarm. The patient that has endometriosis, that you do the ultrasound and you find a papilla or atypical appearance or vascularization of the cyst, this is an alarm. CA125 is not important in diagnosis of endometriosis at all. But in these circumstances, in this situation, it can be. Why? Because you follow this patient in your clinic, you see her on Monday in January, and she has a CA-125 of 56. You see her after 6 months after, you do the ultrasound, something is not good, and she has CA-125 of 951. This is a problem.
Yeah.
So yes, these are from the practical point of view, perimenopausal. And the point is, Madam, if you go in menopause, endometriosis is sorted out, we don't want to see you again. I'm not sure that this is a very precise message that we have to give to our patients.
Yes, and let me add one other point. Thank you so much. I'm completely agree. Another point is after hysterectomy, and if the patient comes into the menopause and somebody decided to give her hormonal replacement therapy, then in case of known endometriosis, the estrogen monotherapy, that is also a critical point. She needs also a combined hormonal replacement therapy, because also in the literature, the known cases with ovarian cancer or extra ovarian cancer, that are ladies after hysterectomy, and then they've gotten the estrogen monotherapy.
Yeah, I think it's a very, very relevant point you're making. And I think the cancer in like endometriosis and cancer, I think this is like more and more coming up in different settings and in congresses. And this is definitely a topic we could actually have a look, because I know that there's lots of genetic and pathway testing, and there are some kind of links that they do think that there are some mechanisms that are related. So maybe in the future we should touch down on this topic as well. So I think for question and answers we have actually run out of the time. Moyad, if you to
one question, if that's okay.
Yes.
I come across a very interesting subject of post-surgical pain syndrome, and I was wondering, very, very good talk from both of you. I mean, the speakers were wonderful. What's your thought about persistent pain after endometriosis surgery? It's not a simple problem, and how would you predict the recurrence of endometriosis?
Yes, so from my side, there's a clear indication for ongoing hormonal treatment to avoid recurrent disease, because especially in the young patients, we avoid or we do organ sparing surgery. Excuse me, organ sparing surgery, and that means we let the uterus in, and there's adenomyosis, so we are not able to remove all endometriotic lesions, and that is also the source for ongoing disease. And also the ovaries, they are going on to produce estrogen, so it's a chronic disease. And I'm always talking to my patients, so it's similar like diabetes. So a patient with diabetes is also not able to stop the insulin if it's needed. Yes. And it depends. You can modulate a little bit the situation with the lifestyle, with other stuff. And if you decided, if the patients decide to stop hormones, it's okay. But then we have to find a balance between disease, symptoms, and life quality. So, but normally we recommend to go on with the hormonal treatment.
Excellent, thank you.
Thank you very much. Just final words. I would like to, on behalf of the participants, the panelists, to thank our speakers, fantastic speakers. It was an amazing 2 hours and very informative. I learned a lot myself, and I'm sure everyone has learned a lot from the talks. So thank you so much. Thank you for our participants for your attendance. Please do not forget to fill the feedback forms in order to get your certificates before you leave the webinar. We are hoping to organize another webinar session next month, and that will be our grand round. We're going to talk about the surgery for abnormally invasive placenta, and keep the education as much as we can, and everybody will be welcome. So thank you, Pele, for chairing the session. Thank you, our moderators. Thank you, Dr. Mazen, and big thank you to our speakers, and enjoy the rest of the weekend.
Thank you, Mike.
Thank you very much.
Thank you very much. Excellent.
Bye bye. Bye bye.
It was a pleasure.
Thank
Bye bye.
Pleasure.
Bye-bye, everyone.